esteemed colleagues from Pakistan and around the world, Honorable Dr. Zafar Mirza, Dr. Shahid Shafi, Dr. Adil Haider, our keynote speakers, Dr. Khalda Sumro, Dr. Alexandra Lansky, Dr. Jamil Tajik, and Dr. Javed Butler. It is a real pleasure to welcome you all to our second annual cardiovascular conference, Pulse 2021. My name is Zainab Samad, and I serve at the Al Khan University as the chair of the Department of Medicine and as a consultant cardiologist. I and Dr. Usman Fahim are co-conveners for Pulse 2021. This conference was started as our contribution to fight the burden, the immense burden of cardiovascular disease in Pakistan. We have all heard about the story of the young man who suddenly passed away from a heart attack, leaving young children and a widow. The young or elderly woman who failed to heed her symptoms and presented too late to be salvaged in the cardiac unit. We have all at some point in our training, in our clinical practice, and in everyday life been haunted by these tragic stories. These represent catastrophes not only for individual families, but they have immense societal and economic consequences. It is our shared humanity and compassion that must drive us as a cardiovascular community to put together our resources and strengthen our health systems to provide care for those with suspected or known cardiovascular disease in our country. And we need to do this optimally for both men and women. We hope that this conference will empower you to be change agents and, at the very least, reflect on the importance of a gendered approach to cardiovascular medicine across the spectrum of policy, individual, and population level care. I wish you all many joyful hours of learning ahead from our superstar keynote speakers and Pulse 2021 faculty. I would now like to pass on the mic to Dr. Saira Bukhari, who is Assistant Professor of Medicine and the Chair of the Scientific Committee for Pulse 2021. She currently serves as the Interim Section Head of Cardiology at AKU to provide her welcoming remarks. Ladies and gentlemen, Dr. Saira Bukhari.
Thank you, Dr. Zainab Samad. I think you encapsulated the misery that we see every day very well. On behalf of the organizing committee, I welcome you all to Pulse 2021. We hope that this conference, which has been a labor of love for us, will prove useful and interesting for all our participants. And we also hope that you will all take away important messages around gender matters in cardiovascular medicine across our inaugural session today, our imaging, interventional cardiology, electrophysiology, and structural heart disease sessions over the next few days. It is now my great pleasure to introduce our new CEO, Dr. Shahid Shafi. Dr. Shafi is a graduate from the inaugural class of AKU's Medical College in 1988. He completed an MPH from the Johns Hopkins University, a residency in general surgery from New Jersey Medical School, a fellowship in trauma surgery and surgical critical care from the University of Pennsylvania, a research fellowship from sunny Buffalo, and an MBA from the Southern Methodist University in Dallas, Texas. Dr. Shahid is a general and trauma surgeon with over 32 years' experience in public, private, and academic healthcare systems. He also served in leadership roles at the American College of Surgeons, American Association for the Surgery of Trauma, Eastern Association for the Surgery of Trauma, Governor of Texas's EMS and Trauma Advisory Council, and other local, state, and national organizations. Dr. Shafi has published 110 manuscripts in peer-reviewed medical journals and is a recipient of many research grants. Prior to moving back to Pakistan to us, Dr. Shafi served as the Market Vice President for Population Health and Chief Medical Officer for Common Spirit, the second largest nonprofit health system in the US, with operations in 23 states. Please welcome Dr. Shahid Shafi.
Thank you very much, Saira. It's a great honor and a privilege for me to be back at AKU. And quite honestly, in the presence of my such learned colleagues, I feel quite ordinary as a surgeon. So when Zainab asked me to say a few words, I sort of started scratching my head as to what can I say that may sound smart, and I realized that I don't have anything smart to say, so I will just share a couple of stories with you. So which really, I think, reflect how far cardiology has come along in a single generation. So the first story goes back to 1988, the year we graduated. One of my best friends from our class, he after graduation, we were all planning to take a trip to the northern areas to celebrate some time off, and we asked this friend of ours to come along with us, and he couldn't come. He said he wanted to spend some time with his parents. And it was just as well, because soon afterwards, his one of those evenings, his father, who was probably about the same age as we are now, he started complaining of some chest pain. They lived right across the street from AKU on near Shahid Middat Road. So this friend of mine put his father in the car and literally just drove him over to the ER of AKU. By the time they put his dad on a stretcher, he had full cardiac arrest. He was in full cardiac arrest. He was successfully resuscitated, and he went on to live another 30 years. And I had the pleasure of knowing him until that gentleman, my friend's father, for a long time. And it was really a success to just basic CPR and timely care in the 80s, which was a far cry from where we are today. The second story that I wanted to share with you is that, after doing my surgical residency, and I was a little slow, it took me 7 years instead of the usual 5, because I spent some time in the lab as well. And then another 2 year in fellowship. So nearly 10 years of postgraduate training. I was finally very proud of myself because I had 2 board certifications. I was double board certified, general surgery and surgical critical care. Until I talked to my cardiology friends, and they were quadruple board certified in the same period of time. They had a board certification in cardiac imaging and electrophysiology and this and that and all the other things that I had never heard of. And that is a testament to cardiology, how far it has come along in the last 30 years because of technological advancement in imaging, electrophysiology, minimally invasive techniques, and all the other things that I can't even name today. And it's just in one generation. I recall when we were student in the 80s, our professors only had a stethoscope and a sensitive fingertip, measuring the pulse or checking the pulse to come up with these massive, big diagnoses of cardiac disease. And here we are now, where we can image the heart in 3 dimensions and know precisely where an electrical impulse is traveling through the myocardium and fix it. So it's a testament to the advancement of science, and it's also a testament to institutions like AKU that have brought a lot of those technological advancement to Pakistan. And at the same time, AKU has also brought along programs like Lifesavers, which teaches basic life support and CPR to the masses. So AKU is a unique institution, and I'm very proud to be part of this institution that has promoted the cardiology all the way from basic life support to advanced minimally invasive procedures to fix structural heart defects and electrical aberrancy. So thank you very much for inviting me to speak with you today. I'm so glad to be in this August company. Like I said, I feel very inadequate as a surgeon to be sitting with all of you smart people. Thank you very much. And the next speaker, I think I have the pleasure of introducing the next speaker. Is that right, Saira? Yep. So the next speaker is Dr. Adil Haider. It's a pleasure for me to introduce him. Adil and I have known each other for nearly all his adult life. But he's now the Dean of the Aga Khan University Medical College and a professor of surgery and community health sciences. And of course, the first alumnus to hold this honor at AKU. He also has a master's in public health from Hopkins. And also, I think he copied me. Is that right, Adil? You copied me, you did a master's in public health from Hopkins, trained as a trauma surgeon, and worked at some of the same institutions that I worked at, but he's much smarter than I am. By the time most of us aspired to publish 40 papers. By the time we turned 40, he didn't aspire. He published like 400 papers by the time he was 40 or something like that, some crazy number. Most recently, he was the Kessler Director for the Center of Surgery and Public Health at Brigham and Women's Hospital and Harvard Medical School. He has mentored hundreds of research trainees, published, like I said, nearly 400 peer-reviewed papers, has served as a principal investigator on extramural grants worth millions of dollars. He is the recipient of several awards. His work in racial and ethnic socioeconomic disparities in healthcare is world-renowned, and he is the recipient of a prestigious honor for civilians in the United States called Ellis Island Medal of Honor for his work in disparities. Adil has also been a leader in responding to COVID-19 pandemic in Pakistan. He has worked towards not only preparing and leading AKU through some of the most difficult part of the pandemic earlier in 2020, but he has also formed several public-private partnerships in partnership with the government of Pakistan to ensure that the quality of care that AKU provides to its patient is also available through telemedicine and other online training to people elsewhere in Pakistan. So it's an honor for me to introduce Dr. Adil Haider. Adil?
Thank you so much, Shahid. And yes, I did follow you, as you well know, but most people do think I'm just sometimes a better looking version than you, so that's okay. I want to just start with actually welcoming everybody to this conference. I know we have more than 100 colleagues who've joined and who've registered. I want to thank our previous State Minister of Health, Dr. Zafar Mirza, our very good friend of AKU, to be our chief guest. Thank you so much for being here, Dr. Zafar. I want to appreciate and acknowledge our keynote speakers, Dr. Alexandra Lansky, Dr. Khalda Sumro, and given the topic, gender matters, I'm thrilled to see that we have a great gender balance in our keynote speakers, that the first two are women. And then we of course have Dr. Jamil Tajik, who I remember when I was a medical student and rotated at Mayo Clinic. So it's so great to have you here, Dr. Tajik. And then of course our very own Dr. Javed Butler, and another very illustrious AKU alumni. I want to acknowledge the presence of our CEO who just spoke. And then of course our department chair, Professor Zainab Samad, and the section head, Dr. Usman Fahim, our service line chief for cardiology, Dr. Amir Hamid, and of course the entire Pulse organizing committee, and those who have joined us, including our medical students, residents, and fellows. You know, after last year's success with the first Pulse conference, and you see Usman smiling there because they put a lot of hard work in putting together that Pulse conference, it's always difficult to say, how are you going to top that the next year? And it's no surprise that the way they figured out how to do it is by picking a topic which is just so immensely important that will continue to accelerate on the energy built last year during the Pulse conference. And that's why this topic, gender matters, and how gender impacts heart disease, or heart disease specifically impacts women, is such an important topic. Now, most people, stereotypically at least, when they think of cardiac disease, they think of a middle-aged man clutching their chest. But we know that's not the real outcome of heart disease. In fact, it is the #1 killer of women. And it not only kills women, it kills them prematurely, with over 2 million premature deaths for women each year, underlying why this topic that my colleagues in cardiology have chosen is just so important. And the worst part is that in our countries, in lower middle income countries, cardiovascular disease further increases the disparity in care between men and women, where women end up receiving on multiple issues worse care. And in fact, our department chair, Dr. Zainab, has shown, just using AKU data, how that is perpetuated. And we know that this is a huge issue in society. So during this symposium and conference, I hope you will discuss issues about the differential presentation of cardiac disease in women, and how we can ensure that they get the best possible care that, of course, women deserve, and how we can all learn how to treat and diagnose symptoms better amongst women. I'll also note that it's so important to ensure, as we talk about gender matters, as Dean, I want to note, it's so important to ensure that women are, attaining the rank of high important positions so that these matters can be pushed forward. And I want to note that our interim section head, Dr. Bukhari, and of course the department chair, I want to note and thank you for all of the important work that you have done. I think at the end of this conference, we should definitely come up with some ways to make a difference, because there are just so many areas where we do need to work hard. You know, AKU has done so much, right? From the first primary percutaneous catheterization in Pakistan, a 24/7 service, to a structured residency training program, to having 3 different fellowships. I mean, AKU has done a lot, but there's a lot more we need to do, including developing programs in preventive cardiology, heart failure, cardiac oncology, and a variety of others, and specifically women and cardiac health. So with that, I wish you all the very best. And I want to just, again, send my extreme thanks to all the folks who put this together, including the convener of today's conference, Dr. Zainab Samad, the co-convener, Dr. Usman Fahim, the organizing committee chair, Dr. Amir Hamid, our service chief, Dr. Javed Tajik, who's the scientific committee chair, Dr. Saira Bukhari, who's the scientific committee co-chair. Our administrative support, especially Sana Mahani, Zara Khan, Salima Karani, and Mariam Gambo, and of course our colleagues from IT, Conference Secretariat, and so on. I thank you so much for putting together today's conference. Now we get to the really exciting part where we get to hear from our chief guest, and then following that, our plenary speakers. As mentioned before, our chief guest is somebody who is extremely well known in Pakistan. Of course, our most recent special assistant to the Prime Minister, or what we usually call our most recent federal health minister. And we saw him, in action during the start of the COVID pandemic. We saw how Dr. Zafar Mirza literally was on the border at Torkham when the first cases were coming in, and then was all across the country. And of course, we know that the initial response of COVID and the initial ability of Pakistan to do well, and all the accolades Pakistan got in the initial part of the pandemic, we know where that came from. That leadership from Dr. Zafar across the country, sir, was so fantastic and remains a role model for so many of us. Of course, your ability to act that way came from years of experience. Before becoming our special assistant to the Prime Minister, Dr. Mirza was the Director of Health Systems Development at the WHO Regional Office for the Eastern Mediterranean. Before that directorship, he led the Public Health Innovation and Intellectual Property Office at the WHO headquarters. And then even before that, he was the regional advisor for essential medications at the WHO. So he's had a long career at the WHO. And before that, he was the founder and executive director of a civil society organization called the Network for Consumer Protection in Pakistan, which has done incredible work in that field. One of the most important things that I personally want to note about Dr. Mirza is his work towards establishing public and private partnerships. I remember a phone call early on in the pandemic with Dr. Mirza, in which I said, "What can AKU do for the government?" And he immediately said, "You're helping us on X, Y, and Z, but now we need help in critical care, and we need you to develop a program towards that." And you'd be happy to hear, Dr. Mirza, that program continues. We're doing hundreds of critical care consults through telemedicine and doing all sorts of trainings, all started from that one phone call that we had. And we are just so grateful that under your leadership, we were able to use all the resources AKU could bring to bear to support the pandemic. So our good friend, it's such a pleasure to introduce you, sir, Dr. Zafar Mirza.
Can you hear me? All right. Thank you very much, Adil, for your very generous and undeserved and a very long introduction. It is really a pleasure to be with you, all of you. I would like to congratulate Dr. Shahid Shafi on assuming as CEO, new CEO of such a prestigious institution that we are all proud of as citizens of Pakistan. And Dr. Zainab Samad for organizing this, and Dr. Saira Bukhari for being such good organizing committee. Well, you have asked me to participate in this as a so-called guest, chief guest, and I've been wondering in my head that how I should and what should I say. But I have jotted down a couple of points which I would like to share with you. First of all, the topic of this conference being gender matter in CVS, cardiovascular diseases, quite a unique topic, I must say. People have not often thought about it, and hence its importance. So my starting statement would be that by adding the word indeed. So yes, gender indeed matter in cardiovascular diseases. I think that in today's world, when we talk about a health problem, it is not possible to speak in the context, at least partly, of the COVID-19. And whereas we have a varying degree of success in COVID-19, and it's a long haul, and we all know that we are swimming with different waves of COVID-19. But I think one thing that we have started realizing now, the medical community especially, is that apart from the fallout of the COVID-19 itself, how it has affected the essential health services other than this emergency. And of course, the kind of attention and the kind of care that is needed, especially for non-communicable diseases, unless they become emergencies, is very notable. So I think over a period of time, as the data will accumulate and researchers like yourself will get numbers, we will realize that how much has been the fallout during the COVID period of diseases other than infectious diseases, especially COVID-19. So having said this, I must also say that even in normal circumstances, and I think Adil very peculiarly characterized a middle-aged man with his hand on his chest, is the kind of image that you get across when we think about cardiovascular diseases. But yeah, I think it's a reality that even in normal, so to say, circumstances, the likelihood of diagnosis and care and treatment for cardiovascular diseases, especially in low and middle income countries, the males usually get that. And so the likelihood of males being diagnosed with cardiovascular disease is much higher. I don't have the numbers, but definitely it is much higher than women, especially in our part of the world. And for also a very socioeconomic reason, because when the resources are scarce and priorities are difficult to set. Obviously, the income breadwinners in the poor household settings get priority healthcare, and that also is a added reason in countries like ours, where the health conditions of women continue to get neglected. Now, what I would like to also emphasize is that the need for, because all of you are sitting in a apex institution, tertiary healthcare, with teaching arrangements. For me, as a student of health systems, what I find also very, very important, and I hope and wish and pray that you will discuss these aspects as well in this conference, are that the need for early diagnosis and the importance of early diagnosis in chronic diseases, and especially non-communicable diseases. And that cannot, in most settings, happen at the tertiary level. So hence, the need for strengthening our primary and secondary healthcare in health system, where early diagnosis can be made, and the early diagnosis is directly proportional to the success of the care of the cardiovascular patients. And everybody would not be coming to the tertiary level directly for a number of reasons: economic reasons, geographical access reasons, etc., etc. So I think what is very important is that while we talk about, and as Pakistan is poised now in terms of gradually advancing towards universal health coverage, it is very important to keep a couple of considerations in mind. And one of them is that at primary healthcare level, how we train our health workforce, whoever is responsible in our basic health units and rural health centers, to be able to diagnose early signs and early conditions which may lead to more serious cardiovascular problems. At the same time, and that's my second point, from health system perspective, is that it is very important also that the package of essential health services must also include not only the curative part, but also the preventive part. And the integration of preventive, curative, and promotive aspects of care must be integrated at the primary healthcare level, which also, of course, includes non-communicable diseases, which are obviously cardiovascular diseases being subset of it, and the women especially suffering from these diseases being a further subset of it. But it all is linked, and that's the point I'm making. So it has to be seen from a system perspective at different levels of healthcare, starting with the primary healthcare level. And my last point is that it is also very important to think integration in our healthcare services. For example, speaking about gender perspective in cardiovascular diseases, women have additional reasons, specific reasons to develop cardiovascular diseases linked with their pregnancy situations, their lactation situations, their hormonal problems. So there are additional reasons and specific reasons with women to develop cardiovascular problems. And if we think about primary and secondary level of healthcare, unless people who are more specifically trained as experts in advanced care of cardiovascular problems, unless they also integrate with the people who are working for mother and child care at primary healthcare level, that kind of intertwining and integration, which comes as a package of essential services, is very, very critical. So I hope that all of you will be discussing threadbare during this conference, not just the nitty-gritty of very advanced conditions and the very specific aspects of cardiovascular care advances, but also in our settings, how it can be integrated for early diagnosis and also with integration with other health programs at primary and secondary care level. On the lighter note, before ending, when I thought about gender matter in CVS, I have to now speak in Urdu, इसलिए कि दिल के मामलात जो हैं उनको मैं समझता हूँ कि मैं उनको कुछ कुछ समझता हूँ और उसमें gender matters a lot. So, so from literary perspective, it matters so much that we have to be very careful about taking care of gender in cardiovascular problems. So I really am very thankful to all of you and 127 participants I can see now who are attending this conference for giving me this opportunity. I wish you very well and a successful conference. But I would recommend that if by the end of this conference, if you can come up with some recommendations which are encompassing the health system rather than by limiting just in the cardiovascular field, would be much more helpful for the policymakers because the social health insurance programs and essential health services programs in Pakistan are now shaping up. And I think it is very important that they take care of all what you think is very important with reference to gender and cardiovascular diseases. Thank you very much for having me, and I wish you a great conference. Thank you.
Thank you, Dr. Zafar Mirza. Wonderful to hear from you and to hear your thoughts about the healthcare landscape in Pakistan. I think we at AKU are constantly striving to serve the most basic health services to the patients, but at the same time also keep advancing the most cutting edge technology, and which is in cardiology especially is right at the cusp of that, where we have a lot to do in the community, but at the same time at the mothership we try to provide services that are not available elsewhere in the country. It is truly an honor and a privilege to introduce our first keynote speaker. I've had the opportunity to work with Dr. Lansky at Yale University, and I wish I had done more work with her. She's one of those faculty members that leaves you in awe of how much they seem to accomplish in a day. And specifically for our theme of gender matters in cardiovascular health, I think, if her career and her accomplishments show most men how to do things right. She is currently a tenured professor at the Yale School of Medicine in cardiology and is a practicing cardiologist at Yale New Haven Hospital. She joined Yale in 2010 as the director of the Heart and Vascular Clinical Research Program and the Yale Clinical Cardiovascular Research Center, which under her leadership has conducted several landmark national and international cardiovascular trials, specifically with the evaluation of new and investigational interventional devices. She also has a dual appointment as chair of cardiovascular research at Queen Mary University in London as part of the Yale and London-based Bart's Heart Center transatlantic research collaboration. Prior to this, Dr. Lansky was an associate professor at Columbia, a director of the clinical services at the Center for Interventional Vascular Therapy, and chief scientific officer of the Cardiovascular Research Foundation, the Clinical Trials Center, which we know CRF is huge in terms of research and physician and trainee education. She has been on faculty at Washington Hospital Center and at Lenox Hill Hospital. In terms of her publications, it's just amazing. She's had, she's been leading clinical and angiographic evaluations of over 500 clinical trials, including pharmacologic and interventional device trials, and leading 2 FDA approval in the United States. She's been the principal investigator on national and international imaging studies, device, drug-eluting stents, and most recently neuroprotection trials, authoring and co-authoring over 500 academic peer-reviewed manuscripts in the fields of interventional cardiology, but specifically also in women's cardiovascular health. She chaired the American Heart Association Statement on Interventions in Women, and most recently the Academic Research Consortium defining neurological endpoints in clinical and cardiovascular trials. She's had several prestigious awards, including a Masters of Arts Privatim from Yale University, several years as top doctors in Connecticut, Thomson and Reuters Most Influential Scientific Minds for Clinical Medicine, Wenger Award for Clinical Excellence in Women's Health, and she's a visiting professor at Fuwai Hospital in China, as well as an honorary professor at University College London. So she is truly somebody we look up to and has just an amazing set of achievements. And we're honored to have you here, Dr. Lansky, and to share your presentation with us. Thank you so much for joining us.
Thank you, Osman. I hope that this is coming through. I want to thank you for this incredible introduction. So here I'm going to share my slides with you. Can you all see that?
Yes.
Yes.
Okay, fabulous. Okay, so again, thank you. It's really an honor for me to be part of your educational session this morning. I think I commend you for dedicating this to women's health. I think now more than ever, we need to focus on this. I couldn't agree more with the previous comments about really raising the standard for our female patients. And this is something that has been part of my career all along, and really from the very early days. And I'm actually pleased to say that I think over the years, we've seen actually big strides forward. And I think it's through these efforts and really coming together and discussing this topic that we can make a change. So, thank you for including me. You asked me to talk about how to build a research career in interventional cardiology. So I'm going to tell you and this group a little bit about my career, give you some tips about, some things that you might want to consider as you go along for success. I think certainly things that have helped me. So again, I'm going to, this is more of a story of one person's career and how that might, help you along the way. I have to say I stayed up last night, so I was keen to see the inaugural here in the United States. It's a very historic moment for us. And I think it does affect us in so many ways, but one of the exciting ways is to open up our frontiers. And we're hoping to have more exchange. You'll see as I go through this that one of the important things is mentorship. And I've always been very, very strong about mentorship and really being able to have the exchange and the collaboration, I think, is fundamental. All right, so talking about women's health and women in this profession, I think there are two books that I want to bring to our females' attention, our colleagues here. One is that I have absolutely, thought was incredible. Unleash the Power of the Female Brain. This is written by Daniel Amen. He's a physician in California. And he really speaks to the influence women have, not in their immediate circle, not in their immediate family, but the extended family, their friends, and also in their professional arena. And I think this is a fascinating book, and I really urge you to read this book because I think it's enlightening. It makes you realize what influence you actually do have and can have on those around you. So a fabulous read. Second read that I would really encourage our female colleagues to look at is Sheryl Sandberg. She's the CEO of Facebook. She wrote this book, Lean In. I think it's a well-known book. But again, for any woman in a profession, I think she brings to life many things and many lessons that she has learned along the way that we all learn from. I think it's a common theme and common challenges. So again, I think this is just two excellent reads for our female colleagues. All right, so innovation is unavoidable. There's no question about that. And that applies to technology. I've been practicing cardiology for over 2 decades now. And I think for all of us who have been in this field, we've all seen changes over time, and we need to adapt to the new technology, but we also need to adapt ourselves in our professional world and what we are doing. And I love this quote from Charles Darwin: it's not the strongest species that survives, nor the most intelligent, but rather the most adaptable to change. And I would challenge you, as you go through your careers, you will be faced with change, and you need to be able to adapt that. And of course, this is a dodo with an iPad, and I think it's a great analogy. But go through your career being open-minded, flexible, and adaptable. I think that is just probably my most important advice to all the young colleagues that are, starting off in their career. So of course, in interventional cardiology, those in the field know this man, Andreas Grunzig. He was the father, the initiator, the pioneer of interventional cardiology back in 1977. We have a relatively young field, and in this space of time, relatively short space of time, there has been an explosion of evidence that has come forward. When he started off balloon angioplasty, the success rates were very low. The failure rates were very high. Bypass surgery, emergency bypass surgery, and a quarter of the patients. I mean, that's unheard of nowadays. I mean, the young fellows that are coming through would laugh at this when they look at this, but restenosis rates, failure rates of up to 50%. And really, this man inspired a whole new field, generations of trialists and clinical evidence, a new method of education that is very sort of demonstration based. And, I think this was the genesis of what we have seen happening in interventional cardiology ever since 1977. If this is too loud, I'll put it down a little bit, but this is my fellowship year, 1997. So it'll tell you a little bit about me and my age. But just to point out on the front here, I was very fortunate to work with some of the pioneers. Kenneth Kent, the late Kenneth Kent, was the first to do interventional cardiology in the United States. Martin Leon, Dr. Sattler, Gus Bouchard, but many others that you recognize on this picture were colleagues. They trained with me, and I was very, very fortunate to be a part of that. So, you know, we went through a little bit of my background. I was fortunate, maybe less fortunate, to be profiled in Cardiovascular News, a very high-ranking journal out there back in 2016. And one of the things it does is these caricatures of you, which I think are very fun. They're fun to look at other colleagues, actually, not so much yourself. But one of the things they asked you are, what are your hobbies? So I'll start with that. I think it's important to realize that we all have and should have fulfilling personal lives, and stick to that. That should be the core of what you do, because that's where you recharge. That is where you will get your energy. I grew up in the Alps. I was born in Geneva, Switzerland. And at the age of 3 years, I was put on skis, and I have loved skiing ever since. So every year, except this year because of COVID, I go skiing. I love to read history and read a lot. I have 3 fabulous children. We play chess. And so those are some of my hobbies. I love to cook and many other things. We went through some of the highlights of my career, at least my highlights. Practiced interventional cardiology in Washington and New York for about 10 years. I spent about 10 years at Columbia as the director of the clinical program there. Fascinating years where I learned. I was overworked, but it was absolutely incredible. And then 10 years ago, I joined Yale, heading up the clinical research program there. So I really spent most of my career in clinical research. From the time as a fellow onward, I am a founding physician of the Cardiovascular Research Foundation. I was lucky to be appointed as the chief scientific officer of the clinical trials program there. And then again, I went up to Yale. Along the way, I've written a few papers and got recognition for that. But I would say that my biggest accomplishment is really a personal one, and that is my 3 gorgeous children, and I'll introduce you to them in a few slides. So again, as we look at mortality trends in this incredible field that we find ourselves in, cardiovascular medicine, there has been tremendous improvements. And, you know, I have to say that I was very lucky because of the timing of when I did my fellowship. And I was in the midst of all these new technologies, devices, minimally invasive approaches in treating patients. And we have contributed to improvements in outcomes. And I think it's important for all of us to recognize, each in our own way, that we do contribute to the improvements of our patients over time. Everybody contributes to this, and we have to feel part of this ecosystem, part of this community. And I was just very lucky, I think, to be part of this at the time that I was involved and when I finished my fellowship. We saw tremendous evolution in devices, minimally invasive devices, from the crude balloons to stents, drug-eluting stents. Some of these devices have, you know, fallen off the wayside after full evaluation, as scaffolds have. Hopefully it's not the end of that story. Interventional cardiology and treatment of coronaries then sort of was steered in the treatment of structural problems, valvular problems, aortic valve, mitral valve, and other structural problems. But with that came an incredible need for clinical evidence. And we continue this journey. It continues to happen. We continue to push the frontiers and build this strong evidence. And that is what we have come to expect. And that is what we currently practice. In 1999, we leave Washington, D.C. as a group and come to New York. So, you know, the Twin Towers, this was long before 9/11 was still there when we came. It was the midst of vascular brachytherapy. I was really in the midst of this. First generation drug-eluting stents, just again, an explosion of clinical research. We were sad to leave Washington, but again, it was very exciting to come to the big city, the Big Apple. And, you know, it felt like it was all ahead of us. Mentorship. I need to recognize this man. This talk makes me a little bit emotional. This man is incredible. So for those of you in interventional cardiology will recognize Dr. Leon, Professor Leon. He is incredibly influential. I've had the great privilege of working alongside Dr. Leon at the Cardiovascular Research Foundation in Columbia. And I think he is by far the most inspiring mentor I have had, but also many others have had. I can tell you that he was a mentor from my very early fellowship years and continues to this day. I had an exchange with him just this past weekend on how to do something and getting his advice. So again, I just bring this up because mentorship is one of the most important things that you can do. And this goes women, men, whoever, throughout your career, not just in the early stages, but all along. So find those mentors. Now let's talk about women in interventional cardiology. This is in the United States. I do not know what the numbers are in Pakistan, but I can tell you that it has been a steep climb. Only to this day, only 4.5% of interventional cardiologists are female. I only have a few here, but they're not many to put up on the slide in the US. And one of these is from Europe, Alaide. But this is the challenge. It has been a challenge and we need to keep pushing. There's no magic about interventional cardiology. There's no magic about this field. We just need to stand and hold hands and come together and do what our male colleagues do very well. And that is come together as a team. And I have to really recognize my friend and colleague, Roxana Mehran. I've worked with her at the Cardiovascular Research Foundation for 2 decades. She's a power woman. She brought this group together. It's through our society, the Women in Innovation, founded this group. I am privileged to be chairing this group now. And again, the partnership is critical. This, I would mention, is open internationally. This is not just a US society, it's an international society. So for all the interventional women sitting here and listening in, please join us. We need you, we want you, and we want you to help shape the future of our field. It's critical. I, very early in my career, was very much interested in addressing some of the disparities that women face as patients. The differences in the outcomes, the differences in the recommendations of guidelines, and some of the disparities. This is what we're dealing with now, is the disparities of females in our clinical studies. We need to boost the numbers. And part of that is that there are not enough women cardiologists or interventional cardiologists to recruit these women, but there are many other issues. And I'm very pleased to be a part of this group, Take Her Health to Heart, large group including AdvaMed, which is the consortium of industry, the device industry, the FDA is part of this, many of the societies are part of this, and we're working collectively to try and address this on a national level. So again, I think this is an important initiative. I bring this up because, again, I want to make the point that for all of you, the key take home here is just to be active and to be engaged in whatever way you can, whatever your strength is, in whatever way you can make a difference, step in and do it. Go back to Sheryl Sandberg's book, lean in, hold hands and take that step to make a difference. whether it's through your clinical practice, taking care of patients, whether it's joining your society, whether it is writing a paper, doing a clinical trial, whatever it might be, but just take the lead and follow your passion. I've done a lot of academic work, a lot of consensus building papers, etc. That is, you know, the little way that I've been able to contribute. In 2004, this is back to my path. We left Lenox Hill and went to Columbia. Columbia is an amazing place. I was very privileged to be asked to lead the clinical service at Columbia, and I did that for a decade. I was asked to be the chief scientific officer of the clinical trials unit at the Cardiovascular Research Foundation. Now, at the time, I was younger and didn't realize that this was 2 full-time positions squeezed in one. The schedule was absolutely brutal, and it was just an amazing time. And you know, the logo for Columbia is amazing things are happening here, and I can vouch for that. It's an incredible institution, ranked #1 in the United States for interventional cardiology. And here's my beautiful children. At the same time that I went there and was doing all of this, I had 3 children. Natalie, the youngest, she is now 16, but she was born when a year after I joined Columbia. Other things that I would highly recommend for all of you listening as you face your careers and move forward is networking. You know, we're in a very challenging time right now with COVID. We link through Zoom. Zoom works. It's nice. It's nice to see everybody on Zoom, but you know, it's being in person, going to meetings, interacting, talking, exchanging ideas, you know, is unbeatable. And I cannot wait to go back to that. I'm afraid that some of the, you know, the Zoom sort of culture is here to stay, but I do hope that we will go back to having in-person meetings. I think they're invaluable for building networks, etc. The focus on education, obviously you're doing your bit here. This is incredibly valuable. It's part of our Hippocratic oath to pass this on. In 2011, I joined Yale, left Columbia and joined Yale. And once again, you can see that while I thought I was going into a more diverse group, I was not. Here I am. I had to get a haircut to kind of fit into the group picture, but joined a wonderful group of male colleagues. There is only one other female in this group. I came to Yale to build the clinical research program. I was certainly very well equipped, understanding all the bits and pieces that need to be part of that. I had all the connections and the network, etc., and have been very lucky to be able to do this and put this in place. It's been sort of a very successful trajectory in the past 10 years. Again, understanding all the components, and I'm not going to go into the details of what is needed, but the benefits of doing a clinical research program at any one of your institutions, I think, cannot be understated. I think clinical research, clinical evidence is key. And from that, your institution will get recognitions. We got kudos for high enrollment in some of the nationally funded clinical studies. We had kudos for national excellence in our hypertrophic cardiomyopathy group through the clinical research program. And of course, linking internationally. So we linked with China, we linked with collaboration in London, and all of these things, I think, really are very helpful to establish yourself in this field. Again, some beautiful pictures, but many, many female colleagues, incredible talent, and leverage your home talent, I think is the key message here. I've always thought that mentorship is vital. So not just for yourself, but for others. These are my summer interns. So I actually open my doors to high school students every year. And this is in 2018, the summer internship, and many high school students who have the opportunity to come and get a flavor of what we are doing in our clinical research program. These are some of the fellows that I worked with that you might recognize. Vivian Ning, who's now a junior faculty at Columbia. Bourkougou, who was a fellow at the time, is now junior faculty at the Charité in Berlin, and many others. And I can go on and on. But anyhow, just to bring this to closure, I think, the past 20 years have been absolutely incredible in this field. And I think there have been many, many collective successes, many fantastic memories, but you will have bumps in the road, as we all do. I don't think this is specific to women. Men have bumps in the road as well, and there are challenges ahead of you. And I think that's just part of what a professional career. I think our field is a unique field, and we should all feel very good to be part of cardiology, but interventional cardiology in particular. One of the things I think is fantastic is the partnerships, the collaborations, the ability to reach out and to be able to talk and be able to work together. Because this world is a global world. Our clinical evidence is built on a global level nowadays. And I think reaching out and doing this. So it's really, feeling proud to be part of this community, I think is something that I certainly feel. And again, none of us do this alone. It's through partnerships, collaborations, talent on the home front. And I just want to acknowledge all the people that I've worked with. Many youngsters, as you can see from these pictures, celebrated, bring them together and create that community. I think it's really vital for success. And of course, your families, acknowledge them, celebrate them. They're wonderful people. Finally, I think we're in a new era. I think yesterday was very historic. And I, again, just look forward to opening our borders and welcoming, hopefully, many of you. Thank you so much for including me.
Dr. Lansky, thank you so much for that wonderful talk and inspiring journey that you shared with us. And I know that there are a lot of students, fellows, and junior mid-career faculty who are going to learn a great deal from what you've shared with us in the past few minutes. So really appreciate you joining, and thank you very much. Our next speaker is Dr. Jamil Tajik. He is a personal hero of mine, and it gives me really a great pleasure to introduce him. He's currently the director of the Cardiac Specialty Center at St. Luke's Medical Center in Milwaukee, Wisconsin. He's the former president of Aurora Cardiovascular Services, St. Luke's Medical Center, Milwaukee, Wisconsin, and the former chairman of the Zayed Cardiovascular Center at Mayo Clinic, Rochester, Minnesota. He received his medical degree from King Edward Medical College, Lahore, Pakistan in 1965. In 1972, he was appointed as a consultant in cardiovascular diseases at Mayo Clinic, Rochester, Minnesota. While at Mayo Clinic, he was director of the echocardiography lab from 1980 to 1992, and chairman of the cardiovascular division from 1993 to 2002. He was named Teacher of the Year by the Mayo Cardiovascular Fellows on 5 occasions and received the prestigious Melvin L. Marcus Memorial Award for Distinguished Contribution as a gifted teacher in cardiology in 2000. He has been the co-director of over 100 cardiology CME courses. His major area of patient care, teaching, and research include imaging, adult congenital heart disease, aortopathies, cardiomyopathies, valvular heart disease, pericardial diseases, and diastolic heart failure. Dr. Tajik also has a special interest in preventive cardiology. His bibliography to date includes over 600 articles and book chapters. He has also co-authored 7 books. Amongst them is the Echo Manual, which every fellow has in their bag all the time. He received the Mayo Clinic Department of Medicine Outstanding Mentorship Award in 2005. Dr. Tajik has received many awards and special recognitions, including the Distinguished Alumnus Award presented by the King Edward Medical College Alumni Association, North America in 2000. He received the Medal of Merit in 2001 from the International Society for Heart Research. He was named the Distinguished Fellow of the American College of Cardiology in 2003. Dr. Tajik was presented the Medal of Excellence by His Majesty, the late King Hussein of Jordan in 1996. He is awarded the prestigious Ellis Island Medal of Honor in 2005. Dr. Tajik was the first recipient of the Lifetime Achievement Award of the American Society of Echo in June 2009. He is one of my personal heroes, and I know of every fellow and colleague that has ever interacted with him, they would say the same. Ladies and gentlemen, Dr. Tajik.
Zainab, I did not know I'm your personal hero. Thank you for that most wonderful introduction. And I would like to thank all of the organizing committee members, scientific committee members, Dr. Javed Butler is following here as a speaker, Dr. Adil Haider, and let's see who's missing from the podium. Yeah, Dr. Shahid Shafi, who's joined you as a new CEO. So when I was invited by the great Dr. Zainab, this could not be turned down under any circumstances. And I'm so pleased to be with you, so pleased to see so many of you there. And also wonderful to hear Dr. Lansky's lecture. That was very inspiring. So gender matters, of course it does. And personally, I think gender matters should include both men and women in it, in that definition, but somehow it's only now implies women. So I chose mitral valve prolapse as a topic to discuss because this affects women more commonly, and it is now become in a subset of women, a malignant disease. So let me see if we are able to see my slides there. Can you see it?
No, you'll have to click share screen and then click on the window first. There we go. We can see that.
Now it's here. Okay. Thank you, Zainab. So I refer to this as a 50-year odyssey, journey of 50 years. It is also not only story of mitral valve prolapse, but it's also a personal journey because I started my cardiology career in 1970. So I've been in cardiology for past 50 years and seen several things happen, fantastic ones in the many fields of cardiology. And today we're just going to focus on the mitral valve prolapse. The story begins with Dr. Barlow in South Africa, Johannesburg, South Africa, where he first described in 1963 that the click murmur was of intracardiac origin, in contradistinction to all previous publications that was an extracardiac noise or feature from pericardium or lungs and so forth. Then this is the key paper where he equated this click murmur to the aneurysmal protrusion, which he referred to as billowing of the mitral leaflets, describe the posterior leaflet first and then bileaflet mitral valve prolapse, or billowing as he preferred to call it. Now, that became well known, but the diagnosis objectively got started with the echocardiography. Of course, this is the M-mode echo, which shows the typical features of the mid-systolic abrupt posterior displacement of the mitral leaflets. Very classic appearance of mitral valve prolapse. This is from Dr. Feigenbaum's laboratory, 1971. So that's when all of this story begins about mitral valve prolapse. And in general, it came to be regarded as a very benign condition, mostly affecting women, young women in particular, and with many neurocirculatory type of symptoms complex. However, occasional reports of sudden deaths were being described. First case in 1966, then in 1968, another case by Barlow himself was reported. But these were not gaining any momentum, traction about this particular calamity that may befall patients with mitral valve prolapse. And subsequently, several other scanty reports on sudden cardiac death in female patients with mitral valve prolapse were reported, but because they were so scanty, it solidified the concept that bileaflet mitral valve prolapse syndrome is a benign condition. Until this particular paper was published from the lab of the famous late Dr. Jesse Edwards, the premier cardiac pathologist who used to be at Mayo, and then towards the end of his career left and was at the University of Minnesota. And in this paper, they had 14 cases of cardiac sudden death attributed to mitral valve prolapse. These were relatively young people, and as I've highlighted here, 11 of the 14 were females. So again, now it pointed to something that, yes, this is serious, significant number of sudden deaths in young females with mitral valve prolapse. We launched a study at Mayo Clinic at that time to look at the longitudinally patients diagnosed with mitral valve prolapse and essentially asymptomatic. This study, of course, was led by no other than Rick Nishimura, the famous cardiologist in valvular heart disease, and several of my colleagues at that time at Mayo Clinic. 237 patients, a general mean follow-up of 6.2 years. And there was high risk for the development of progressive mitral regurgitation, including complication of sudden death and CVAs and infective endocarditis in a subset of individuals with mitral valve prolapse. And that subset turned out to be patients who had thickened mitral leaflets, 5 millimeter or greater thickness. So the bottom line of this slide would be I'm focusing on the malignant mitral valve prolapse syndrome. And you see here that mitral valve prolapse sudden death incidence was 0.4% per year. US general population sudden death rate is 0.1% per year. So fourfold increase of sudden death in a subset of individuals with mitral valve prolapse. That paper, 1985. Very little occurred after that. Few other papers came up, supported this concept, but no more traction took on this subject. But redux or reawakening of all of us about this particular calamity in mitral valve prolapse has occurred. And it started with this paper from Mayo Clinic, from my colleagues there, published in about 8 years ago. And this is examination of 24 out of hospital cardiac arrest individuals. And you'll see they had bileaflet mitral valve prolapse, and majority again were female. And the authors conclude with this particular paper, as you can see, the title was Malignant Bileaflet Mitral Valve Prolapse. The authors describe a subset of individuals with mitral valve prolapse that experience life-threatening ventricular arrhythmias. The phenotype was characterized by bileaflet mitral valve prolapse, female gender, and frequent extrasystoles. So they presented one picture of high-risk individuals. That's 2013. And then in 2015, group from Italy did tremendous work here. Again, Dr. Cristina Basso, fantastic pathologist there, published series of analyzed series of patients because they have a registry of all sudden deaths. In northern Italy, they have all tabulated those, and therefore they were able to find from the cardiac pathology registry of 650 young adults less than age 40. That is the criteria. Younger individuals with sudden cardiac death, and they found their mitral valve prolapse in 43 patients, and 26 of those patients of 43 were females. Again, a preponderance of young females experiencing this particular calamity. And they emphasize in their conclusion that it's an underestimated cause of arrhythmic sudden death, mitral valve prolapses, mostly in young women. Again, papillary muscle and infrabasal left ventricular wall is stretched. There's tugging of that going on. This myocardial stretch leads to arrhythmias and leads to fibrosis of that portion of the left ventricle, posterolateral wall of the left ventricle. They followed this paper, pathological paper, by clinical and did MRIs on these individual patients. And they conclude again the same aspect that after looking at the MRIs, they document localized area of fibrosis in the posterobasal wall of left ventricle. But in addition to that, they bring out a new anatomic finding, or again, a redux of a finding that was previously described by pathologists, and that is referred to as mitral annulus disjunction. And I'll show some examples of that as one of the reasons why there is excessive motion and why there is fibrosis and arrhythmias. And we'll talk about that. And mitral annulus dysfunction in this MRI example is the separation of mitral posterior leaflet as anterior to, but here posterior leaflet, attachment to the left atrial wall during systole from the posterior wall of the left ventricle. See, this gap has developed. This is referred to as mitral annulus dysfunction, disjunction. And yes, it also leads to mitral annular dysfunction as well, because there's systolic expansion of mitral annulus in this particular syndrome. And delayed enhancement images show what is white here is the fibrosis in the left ventricular wall, both posteriorly and infraposteriorly noted in this example. So this was their seminal finding. And it turns out that one does not require an MRI for diagnosis of this disjunction of the mitral annulus. And echocardiography is very well poised to see that. And in this example, again, if you look at the age here, young female, bileaflet mitral valve prolapse, mitral annulus disjunction. In systole, as the leaflets billow back into the left atrium, you can see there's gap that develops between the mitral leaflet and the left ventricular wall, mitral annulus disjunction. This individual was bothered with tremendous rhythm issues, non-sustained ventricular tachycardias, and an ICD was implanted, and slowly her LV function has improved as well. Here is the ICD lead that can be seen. Now, the other feature they described on the MRI, I will point that out. This is the key reason why malignant mitral valve prolapse develops. Bileaflet mitral valve prolapse is evident here in this apical long axis view of the echo. You can see there mitral annulus disjunction is evident here. Note that this particular wall of the left ventricle is hypercontractile. And importantly, pay attention to how this posteromedial papillary muscle is being, so as to say, pulled, tugged, or jerked. And that whole aspect is arrhythmogenic. Mechanical arrhythmogenesis develops in this region of the left ventricle. And all the EP studies have documented arrhythmias, PVC origin around papillary muscle and in this region of the left ventricle. So this is the key feature of the malignant mitral valve prolapse syndrome morphological features. Now, because of this rapid motion in this area and contractility, we got interested to see what happens to the tissue Doppler analysis in this region of the left ventricle. And my colleague, Dr. Lakshmi Muthukumar, and others from Aurora St. Luke's Hospital here noted there was a very peculiar spike on the tissue Doppler resembling the spiked helmet, German spiked helmet like this. And I'll show you an example of that here. So here is the tissue Doppler findings along that posterolateral wall of the left ventricle. And you can see that during mid-systole, there's a tremendous spike. Never detected before, and I don't know why, but our group has documented that very regularly in such a high-risk individuals, particularly if the velocity of the spike exceeds 16 to 18 cm in these particular cases. So higher the spikes, the more the arrhythmogenic milieu exists in an individual with this kind of morphofunctional abnormality. Okay. So I'm going to illustrate one case here. This is a young female again, relatively young, 49-year-old, presented with palpitations and presyncopal episodes. And then, of course, she got studied by us in a very regular, detailed manner. Clinically, she had a mid-systolic click, a late systolic murmur, and had mild to moderate mitral regurgitation. And ECG showed inferior inverted T waves, recurrent and non-sustained ventricular tachycardia on Holter monitoring noted. And because of these episodes, we had implanted an ICD in her heart, and she had 7 ICD appropriate shocks. And for that reason, in spite of all our medical treatment, we decided that mitral annulus disjunction should be removed in her case. Mitral valve repair should be done, and well, that should be able to help. So this is her preoperative echocardiogram, and you can see the typical features now that you have recognized: bileaflet mitral valve prolapse and mitral annulus disjunction. Left atrium is enlarged, mitral annulus is dilated, and the left ventricular function is normal. And this is the post-op study. Now, on the top left are the pre-op long axis on the top and apical long axis at the bottom. And on the right part of the screen, you can see that the mitral valve repair has been performed, and the annulus is now no longer disjunction. There's an annuloplasty ring there, and the posterior leaflet has been fixed. So that's totally removed. And we also note, as expected, that her spike, annular spike, which preoperatively was 40 centimeters. Normal systolic spike, the annulus is in the range of 10, 12, maybe up to 14, but these are huge areas of hypercontractility, and post-op, you can see it's all normalized now. I just recently saw her in follow-up. She's been followed for close to 3 years now, totally symptoms-free, and is one of the happiest patients you would see in your practice. So I'm going to end my presentation with a review article that we just recently published. Again, Dr. Muthukumar being the first author, she has done a lot of excellent work in the analysis of this particular malignant mitral valve prolapse syndrome. And this was, as I said, recently published in JAMA Cardiology. So the key features from that I bring out. There's another condition that you all are familiar with, hypertrophic cardiomyopathy. Now, everyone knows that patients with hypertrophic cardiomyopathy experience sudden death, and we have algorithms now how to assess them for that particular high-risk feature to implant an ICD. But such does not exist. Such attention does not exist for patients with mitral valve prolapse. So in this, we have kind of summarized what is the sudden death rate in the general population in the US. With MVP, as you saw with our Nishimura study, 0.4% per year. Others have published like this. So somewhere here lies the truth. And with the HCM patients giving the benefit that there's 2% per year. And others will argue it's lower than that, but that's 2% per year. Now, with the prevalence of these conditions, estimated total patients at risk of sudden death from mitral valve prolapse are greater than patients with hypertrophic cardiomyopathy. And that's one message, important message, I believe, for patients with, excuse me, thank you, for patients with the mitral valve prolapse, that the risk of sudden death in the population of this subset is much high because the prevalence of mitral valve prolapse is much higher. 2% of the population has mitral valve prolapse. That's shown right here. So let's pay attention to these patients and do a systematic risk assessment. Now, this is the kind of the central figure for this paper. On the top left, we show the morphology of bileaflet mitral valve prolapse, and importantly, of MAD, which is the mitral annulus disjunction. We show quantitatively very high level of hypercontractility as by tissue Doppler, and here is the MRI demonstrating similar features. Now, another technology which is relatively new is assessment of not only global longitudinal strain, but of myocardial work. And what is red is zones of high work area. And immediately you can see that posterolateral segments of the left ventricle are working extremely hard, hypercontractile. So translate that, and I'm skipping that side of the slide. Here are the complex PVCs, very classic inferior T-wave inversions in these individuals. This is a very specific finding, but only seen in about 30 to 35% of individuals with malignant MVP. But when you see this, your index of suspicion needs to be high, inferior T-wave inversions. And of course, here's a patient with ICD, discharge appropriately. So the concept we have proposed is that MRI delayed enhancement, as shown in these particular segments here, is a late feature. A lot of individuals start off with the triggers of these particular features: high contractility, big amount of stress on these papillary muscles that results in arrhythmogenesis. And they are at high risk, even much before development of fibrosis in the posterolateral wall of the left ventricle. So the triggers are here, and substrate, which is the fibrosis, develops later in the natural course of these individuals. So malignant mitral valve prolapse, this is the time to pay attention to detection of and prevention of sudden cardiac death. So this is what is the most recent information in this particular small subset of individuals with mitral valve prolapse. It's an exciting journey, And of course, exciting journeys has to continue. And I thank you for your wonderful and kind invitation.
Thank you, Dr. Tajik. It's tough to follow you, and thank you. We're mad about mad now. And I'll have you know that I've got the Echo manual on my shelf behind me. So you've been a student, a teacher by proxy for all of us. And thank you for making the point that we are talking about gender and it's not just women. So now it is my profound pleasure to introduce Dr. Javed Butler, our next keynote speaker. Dr. Javed Butler, MBBS, MPH, MBA, is the Patrick Ashley Hand Chair in Cardiovascular Research and Professor and Chairman of the Department of Medicine at the University of Mississippi Medical Center in Jackson, Mississippi. He is also a professor of physiology there. Prior to joining the University of Mississippi, he was the Charles A. Gargano Professor and Director of the Division of Cardiovascular Medicine, as well as co-director of the Heart Unit at Stony Brook University, New York. He has served as the Director for Heart Failure Research at Emory University and the Director of the Heart and Heart-Lung Transplant Programs at Vanderbilt University prior to that. He received his medical degree from the Al-Khan University Hospital and then completed residency training at Yale University, cardiology fellowship and advanced heart failure and transplant fellowships at Vanderbilt, and cardiac imaging fellowship at Mass General Harvard Medical School. He has completed his Master of Public Health degree from Harvard as well as an MBA from the Emory University. Dr. Butler is board certified in cardiovascular medicine and advanced heart failure and transplant medicine. His research interests focus on clinical trials in patients with heart failure, and he serves on several national committees for the American College of Cardiology, American Heart Association, National Institutes of Health, US FDA, and the Heart Failure Society of America. He is the recipient of the Simon Dack Award by the ACC, as well as the Time, Feeling, and Focus Award by the AHA. He has also authored more than 700 peer-reviewed publications and serves on the editorial board of several peer-reviewed cardiovascular journals. He has also been cited numerous times in America's Best Doctors list. Please join me in welcoming Dr. Javed Butler.
Dr. Javed, you're on mute. Dr. Javed, you are on mute.
Okay, I think we should be okay now.
Yes, we can hear you.
Yes, we can hear you.
Okay, great. No matter how many Zoom meetings you do, at the end of the day, you still forget to unmute yourself. So my apologies. So thank you very much for that very kind introduction, and thank you very much for the invitation by the organizers to present in this forum. Obviously, being a graduate of the university, it's even bigger of an honor for me to present this, and hopefully one of these days we will be living in a post-COVID world where we can see each other and do some of these things in person and not only virtually. And also, it's absolutely an honor to listen to Dr. Tajik again. Like Dr. Samad mentioned, he's been a hero for many of us. And you can absolutely never get tired of listening to him and learning from him. So the task that was given to me was to talk about the evolution of heart failure. It's a tough topic because there is so much going on in the field that to go into the details and the nuances are tough in a short time frame. So I will take a step back and give you a sort of a 10,000-foot view on the topic, and then we'll be happy to answer any questions. These are my disclosures. Please do realize that I'm working as a consultant with a lot of the companies that are developing products in the heart failure space. So keep that in mind as you hear my comments. So to begin with, why I spend some time thinking about heart failure, because the prognosis is horrible for these patients. Again, I don't want to become infantile and start comparing diseases, that my disease is more important than your disease. But I mean, this literally, the prognosis is much worse than post myocardial infarction, post stroke, post many forms of cancer. And yet our mindset is not the same when we think about heart failure. I mean, just think about even diseases like dyslipidemia or hypertension. You will never leave a person alone with a blood pressure of 180 or LDL of 180 to say, well, we'll treat you when you develop some more symptoms, whereas in heart failure, despite a 50% 5-year prognosis, it is just incredibly common that people are not on either appropriate therapy or optimal doses. And the idea here is that, when you start developing more symptoms, we will optimize the therapy. So my first sort of plea is that heart failure is not a symptomatic disease. We have to treat the pathophysiology regardless of the symptoms because the prognosis is horrible. It's not only the so-called hard outcomes like mortality, morbidity, hospitalization, but a major impact on quality of life, functional capacity, and health status as well for these patients. So here's my second plea. And my second plea is that, again, we think a lot about prevention of vascular disease, whether it is a stroke, whether it is myocardial infarction, peripheral vascular disease, but we don't think about prevention of heart failure per se. Everybody on call today and in this virtual seminar should realize that they have 1 in 5 chance, almost 20% chance of developing heart failure during their lifetime. So this is not a rare disease, very high risk of developing heart failure during your lifetime. And we are not impotent against this disease. There is a lot that we can do to prevent heart failure. Obviously, I mean, I sort of laugh, you see all these hypertension trials, and again, everybody focuses on MI and a stroke, whereas there's like 50% reduction in heart failure, but we don't necessarily think about it. But low salt diet, exercise, weight loss, blood pressure control, lipids in high-risk patients, there's a lot of things we can do to prevent heart failure, but I specifically make a point is that now there is so much data that has come out in patients with type 2 diabetes, regardless whether you have atherosclerotic cardiovascular disease or not, regardless whether you have primary prevention or secondary prevention, whether you only have risk factors. And the data are phenomenal across board for all SGLT2 inhibitors to substantially reduce the risk of new onset heart failure by about 30% or so. So this is my second plea, and that is to think a little bit about prevention of heart failure, especially in patients with diabetes. So that takes me to the core of this matter today, which is heart failure. In the interest of time, I will only focus on heart failure with reduced ejection fraction and won't go into heart failure with preserved ejection fraction. So I just served my 5-year term on the ACC-AHA Guidelines Committee. So this is the first set of guidelines that we came up with in 2013. When I was a medical student, the way you treated heart failure was basically digoxin and diuretics, and that was the end of it. But then there was a lot of evidence that came out with ACE inhibitors and beta blockers and mineralocorticoid receptor antagonists. And all of these things, everybody on this virtual meeting knows, so I won't go into the evidence base for that, but the evidence over the past, before 2013, the previous 2 decades, had multiple trials that showed that all patients with heart failure and reduced ejection fraction who do not have a contraindication or intolerance should be treated with triple therapy. They should be on an ACE inhibitor, a beta blocker, and a mineralocorticoid receptor antagonist. Beta blocker was evidence-based beta blockers because some of the beta blockers did not improve outcomes. So carvedilol, long-acting metoprolol or bisoprolol, and the evidence with MRA was with spironolactone or eplerenone. So pretty simple guideline, really not a lot of segmentation that everybody should get that. So how did our thought process evolve from 2013 to now over the past 5 to 7 years? Well, the first thing is that we were only working on one side of the ledger. So if you sort of think about heart failure, whatever the insult was, that led to a decrease in ejection fraction. You had a myocardial infarction, you had adriamycin toxicity, whatever it was, and your EF used to be 60%, and now it dropped to 40%, 35%. Logic would say that your EF would just stay there in the absence of another insult. But we know that doesn't happen. If you leave a person alone, even in an absence of another heart attack or another exposure to adriamycin, the EF will continue to drop and will become 30 and 28 and 25. So why is it so? And the reason for that is that there is neurohormonal activation. And once we realize that the neurohormonal activation leads to worsening of heart failure is when we develop all those therapies like ACE inhibitors and beta blockers and MRA. However, Mother Nature also had good neurohormones that are activated to counteract the bad neurohormones. So before 2013, our focus was only to attenuate the bad neurohormones. And what changed is our thinking of not only attenuating the bad neurohormones, but accentuating the good neurohormones to try to bring that balance. And that is what we did with neprilysin inhibition. Neprilysin is an enzyme that degrades a lot of the good vasoactive peptides. And by giving neprilysin inhibition, you can try to bring the balance between the good and the bad. That was tested in this trial called Paradigm HF, the largest trial ever done in patients with heart failure, reduced ejection fraction. The head-to-head comparison with ACE inhibitor when valsartan sacubitril was given, there was a substantial 20% reduction in the risk of cardiovascular death and heart failure hospitalization, 20% reduction in mortality risk by itself. And when given to high-risk patients who are in the hospital with decompensated heart failure, there was even a more substantial reduction in risk and very substantial reverse remodeling and improvement in cardiac function. The second study that subsequently came out was with ivabradine, a SHIFT trial, which was a drug that specifically works on the sinus node to reduce heart rate. This is not a drug for atrial fibrillation patients, only in sinus rhythm. And despite beta blocker therapy, not instead of, but despite beta blocker therapy because of tolerance or despite higher doses, if your heart rate persists more than 70, because heart rate has a linear relationship with prognosis in heart failure, if your heart rate is greater than 70, patients were randomized to ivabradine or placebo. And as you can see, there was a reduction by lowering the heart rate with ivabradine of combined endpoint of cardiovascular death, heart failure hospitalization, which was largely carried forward by heart failure hospitalization. The cardiovascular mortality itself was not significant. So then in 2018, we changed the guidelines a little bit. And basically, it was a still triple therapy, but the guidelines basically added a class 2 recommendation that if your heart rate is still high, then consider ivabradine. But basically, the fundamental change was, yes, beta blocker, yes, MRA, but now the recommendation is that unless and until there are cost or tolerability issues or some sort of real life issue or the drug is not available, barring any of those real life reasons, that the patient should be switched over from an ACE inhibitor or an ARB to an angiotensin receptor neprilysin inhibitor or valsartan sacubitril. So that was an update. So what has happened since then? Well, what has happened since then is that I showed you the heart failure prevention data with SGLT2 inhibitor, but if a drug can prevent heart failure, the question is, can SGLT2 inhibitors treat heart failure? I won't have the time to go into the details of the mechanism of action for SGLT2 inhibitors, but one question that came up is that while these drugs were developed for the treatment of diabetes, they have so many beneficial effects on the heart, kidney, vasculature, and metabolism that perhaps these drugs can improve outcomes irrespective of diabetes, that these are cardiovascular risk modifying agents. So when the heart failure trials started, these trials were completely agnostic of the presence or absence of diabetes. Doesn't matter whether you have diabetes or not, the patients were enrolled. The first trial that came out was DAPA-HF with dapagliflozin. This trial literally sort of proverbially hit it out of the park, see how quickly the curves separate. And on top of 90+% RAS inhibitor use, 90+% beta blocker use, 70+% MRA use, very good baseline therapy, one can see substantial reduction in mortality, morbidity risk. And this is the point that I wanted to make. You know, I, as a clinician, have a lot of inertia. You see a patient in the clinic, the patient is quote unquote doing okay. And you say, you know what, maybe I'll change the medications next time. Here, the p-value for significance was achieved on day 28. I mean, these are really rapid benefit, and the longer we don't give our patients, the more the problem. And the second trial that looked at SGLT2 inhibitors in heart failure with reduced ejection fraction was EMPEROR reduced trial with another SGLT2 inhibitor, empagliflozin. And this trial enrolled a little bit sicker patient population. And again, substantial reduction in cardiovascular death, heart failure hospitalization, renal preservation in every way, shape, or form the trial was positive. So now you have 2 positive trials with SGLT2 inhibitors. Now, if you chart the course or the natural history of heart failure patients, what we are talking is this orange bar in the middle. So you develop heart failure, you get on your triple therapy, ACE inhibitor or beta blocker, your risk goes down, but sooner or later, patients start breaking through that stability. And that is what is now we are terming as worsening heart failure. People who are, despite stable medical therapy and doing okay, are not doing okay anymore. So there was another trial done specifically focusing on these worsening heart failure patients with a drug called vericiguat, which is both a stimulator and an enhancer of nitric oxide efficiency on soluble guanylate cyclase, increases cGMP PKG signaling. And as we know, this is a diffuse signaling pathway that affects the heart, kidney, and the vasculature. That was tested in this trial called Victoria trial. So these were not your outpatient, but these were patients that were recently hospitalized. The bottom line is that the trial showed a 10% reduction in the risk of cardiovascular death or heart failure hospitalization. So some of you or myself had this reaction, you know, all these other trials had a 20-25% relative risk reduction. This 10% doesn't look as much. But look at the placebo event rate. Because worsening heart failure patients are at a high risk, you're talking about 1-year placebo event rate of more than 35%, unbelievably extraordinarily high risk group of patients. And when you have a very high risk group of patients, your 10% absolute relative risk reduction translates into a pretty substantial absolute risk reduction. So this is a really busy slide, but the point I just want to make here is that if you look at the placebo event rate in the Victoria trial, that is 2 to 3 times higher in Victoria trial than the other trials, which then translates into the absolute risk reduction of 4.2%, which is comparable or even better than the other drugs. And if you give it to patients with somewhat lower NT-proBNP levels, the risk profile gets even better. So to wrap up my talk, a couple of other quick things. We know that iron deficiency leads to a lot of symptoms. Iron deficiency not only works through anemia, but iron is specifically involved in ATP generation in the mitochondria, so it has more diffuse effects regardless of anemia. That was tested in another trial, came out in Lancet about 2-3 weeks ago, called AFFIRM-HF, people with heart failure, reduced ejection fraction, with iron deficiency, irrespective whether you have anemia or not, when that iron was replaced, as one can see, remarkable 26% reduction within 1 year of recurrent hospitalization. The only trial that did not really impress us a lot was omecamtiv mecarbil, came out in New England Journal, I think 2 weeks ago, looking at a myosin activator, omecamtiv mecarbil. Because the trial was not very positive, I won't go into the details of this trial. So the bottom line is where we are with heart failure right now, that we have shown that modulation of 5 pathways, angiotensin II, norepinephrine, aldosterone, neprilysin, and SGLT2, with 4 drugs, ARNI, beta blocker, MRAs, and now SGLT2 inhibitors, can improve lifespan by almost 6 years. And this will be the new foundational standard of care, which then raises the question, SGLT2 inhibitors prevent heart failure, SGLT2 inhibitor treat heart failure with reduced ejection fraction. What about heart failure with preserved ejection fraction? Well, we don't have a definitive data, but a smaller trial of about 1,000 patients that had both heart failure with reduced and preserved ejection fraction was recently published, and in these patients with preserved ejection fraction, there was a signal of benefit. So we are very enthusiastic, and there are 2 large trials, EMPEROR, PRESERVE, and DELIVER, in heart failure with preserved ejection fraction that are ongoing. Both of them will report either at the end of this year, 2021, or early 2022, and can't wait to find the results. And this is my last slide. None of this will matter if we don't treat our patients. And unfortunately, there still remains huge gaps that despite of all of this evidence base, the actual provision of therapy to the patients does not occur. There is a lot of inertia, and we still continue to think heart failure as a symptom disease, and sort of patients are sort of hanging in there. Remember, when the patients in our clinic tell us they are doing okay, they're doing okay because they have lowered their expectations from their life. They don't do what they used to do. They are asking other people's help. So that doing okay is a very low bar. I can bet you, forget about treadmill. If you just ask them to walk in the clinic, you would realize how limited they are. So my two pleas on which I will end the talk: one, think about preventing heart failure, and two, don't worry about the symptoms. Treat with the foundational therapy as aggressively as you can. Thank you very much for the invitation, and I really appreciate being on this forum.
Javed, that was an absolute powerhouse of a presentation. Thank you for redefining okay for us. And we realized that inertia seems to be a global problem amongst physicians. So thank you for waking us up and making us realize that we need to change our prescriptions. So thank you for that talk. I now have the profound pleasure of introducing one of our own, somebody who has served Pakistani society for a very long time. Professor Dr. Khalida Sumro holds the distinction of being the first female interventional cardiologist in Pakistan. Dr. Sumro graduated from the Liakal Medical College of Sindh University. She then attained a diploma in cardiology from NICVD and Karachi Institute, Karachi University, and then further a doctorate in cardiac medicine from Liaquat Medical College, Sindh University. She is a fellow of the American College of Cardiology, as well as of the Asia Pacific Society of Cardiology. As a female leader in the field, she was the first female president of the Pakistan Cardiac Society, and I still remember the excellent Pakistan Cardiac Society conference that she conducted. She is also the president of the Women and Heart Diseases Scientific Council of the Pakistan Cardiac Society, as well as the coordinator of the global initiative Go Red for Women program in Pakistan. For her tireless efforts for the community, as well as her clinical and academic services in the field of cardiology and intervention, Dr. Sumro was presented a Lifetime Achievement Award by the Pakistan Cardiac Society in 2017. She is also the recipient of a Civil Award by the President of Pakistan, which is the Tamgha-e-Imtiyaz, roughly translated as the Medal of Distinction. Please welcome the Pride of Pakistan, Dr. Khalida Sumro.
Dr. Khalida, your mic is muted.
Yes, we can hear you, Dr. Khalida.
Yes. Yeah, I'm trying
Maybe,
to.
yes, we'll get
Can
the
you hear me?
slides up. Yes, we can hear you, and we'll get the slides up in a second. So Irma, if you can share the slides again. Dr. Khalida, you can begin your talk.
Yes. Okay. ठीक first one open
स्क्रीन शेयर की
huh
Dr. Khalida, we can hear you. Why don't you go ahead and begin the presentation? We've got the slides up over here as well. Go ahead and share your thoughts.
okay
चलो स्क्रीन शेयर की
करके
कुछ स्क्रीन शेयर की
screen
शेयर स्क्रीन की
is my screen is shared.
Yes, Dr. Khalida, we actually have your presentation up over here. All you have to do is just tell us to advance the slide, to move to the next slide when you need us to do that.
Oh, નથી થઈ. અગિયારથી વઈને ને?
એ પોતે ચીંજીના નતા.
અચ્છા. હા, ઠીક, okay. So, thank you so much, organizers, for inviting me for this lecture. I'm honored. Sharing this slide, our first slide, is my objective is to introduce my colleagues who are working hard to control the CVD and its mortality in Pakistan. We know that we are interested in this topic, not because of the sex, but it is because of the gender, socio-cultural attribute of the biological sex. Woman has a complex social network which is responsible for her different incidents and risk factors for cause of cardiovascular disorders. There is variation in the risk factors in Pakistan. Women in Pakistani culture are undereducated, married at an early age, have no awareness about the modifiable risk factors still. The economical and psychological dependence on male restricts their access to the health care. Other reasons could be under recognition of CVD in women, which is different treatment strategies and decreased female representation in the clinical trials. Not only the CVD is affecting women only, but we can see that it is undermining the socio-economical development of women and their families as well as nation. Though it ranks low, but this is scarcely acknowledged fact that CVD is women's greatest health threat. It is killing more women than the other non-communicable diseases combinedly. Major CVD include IHD, stroke, hypertension, heart failure, rheumatic heart disease, and CHD in Pakistan. We can see from this slide that the risk factors are almost same as male and female, but we can hypertension is greater in women in more than 65 years of old women, and diabetes is again common in women than men. Dyslipidemia in men, whereas sedentary lifestyle surprisingly is more common in men than the women. Obesity is more common in the women than men. If we are talking about the last century, when it was said that ischemic heart disease is common in the male, and it was assumed from the very few studies which were conducted during that decade. This slide was taken from the study from the Professor Azhar Faruqi, who wrote a book in the Hearst, and which shows that there is increased hypertension in the female, as well as more in the urban areas than the rural areas and other parts of the country. Hypertension was more common in urban Karachi and rheumatic heart diseases were more common in the Chitral. Whereas if we look into the data of various hospitals, because there were very scanty studies which were conducted in the Pakistan, and we don't have the data from those studies. So the hospital records were showing that there is increased incidence of the rheumatic heart disease in and hospital admissions at their time. As the Jamil Tajik Saab told us that there was during that era, there was increased incidence of Barlow syndrome, that was the mitral valve prolapse. And the same applies for the rheumatic heart disease, and patients with mitral valve involvement with the rheumatic heart diseases were more in that era than the male patients who were having aortic valve. We can see from this slide that this slide was again taken from the present chapter of the book from Hurst, which shows that there was increased incidence of ischemic heart disease during 1970s in both populations, whereas the gender was not highlighted in that era. Only we can see that rheumatic heart disease were common in Multan and Karachi in that period. But if we see into the another data from the hospital, I remember when I was working in the Liaquat Medical College Hospital, so during the conference, a brochure was published. I took the data from that brochure, and which shows the incidence of acute myocardial infarction, unstable angina, arrhythmias, and hypertensive heart disease. It shows that acute myocardial infarction was relatively less common than the men. And unstable angina again was very low, incidence was very low. 30 versus 171 acute myocardial infarction admissions, and unstable angina 12 versus 50 admissions of the unstable angina during 1971, 1 year data. And then arrhythmias were found in 12 female versus 19 in male. Rheumatic heart disease. Yes, this there were increased admission in the hospital, almost equal 43 and 42 in females, and CMP was again relatively more common in female. If we see the data of the male patients' admissions. And this was the data which was collected from Hyderabad. Hyderabad is the city where only cardiac center was present in entire Sindh at that time. Later on, various institutes were established in the entire Sindh, but Karachi and Hyderabad were the places where the cardiac centers were established, and Hyderabad was having only one cardiac centers, and this is the data taken from that institute. So, if we move forward and look into the data from the American Heart Journal, author was Zafar, which was the faculty member of the Aga Khan again. In her publication, she showed that there is increased incidence of the coronary artery disease, that was a 30.0% versus 23.7% in men in Karachi. And the factors independently associated with the coronary artery disease were current use of the tobacco at that time. Systolic blood pressure again was one of the reasons. Another study by Jafar et al., which showed that females were having more risk factors, especially BMI, systolic blood pressure, diastolic blood pressure, triglycerides, and HDL, which were the reason for increased incidence of coronary artery disease in Karachi city, which is the urban area of the Pakistan. Women were having more diabetes, and that increased diabetes was in consequences of the increased obesity, and this increase that was 65% present in the women, and they were the leading cause for the hypertension as well. In that era, inter-heart study. The inter-heart study was conducted again in collaboration with Pakistan Center as well. And the head of the department, Dr. Khawar, was the coordinator from the Pakistan. And this inter-heart study revealed that the measures which were significantly associated with a 3.5 increase odds of the myocardial infarction in women in comparison to 2.6% in men, with a population attributable risk of 40% in women and 25% in men. So this study showed that male develop myocardial ischemia 8 times more, 8 years earlier than the female. And these shows some highlighted factors which emphasizes that our urgent need to explore the reason behind the enormous burden of the cardiovascular disease and presence of the risk factors in women, which was suggested by inter-heart study. In 2008, again, a study was published in the Pakistan Heart Journal, which shows that there was increased incidence of coronary artery disease or ischemic heart disease in urban population versus the rural population. 5.5 versus 4.3% in the rural population because of the healthy lifestyle comparatively in the rural population. Later on, due to the increased awareness and the efforts taken by the Pakistan Cardiac Society through symposia, conferences, there was increased awareness in the women, and the further studies showed that there was increased incidence of women after the age of 65 years, and the mortality, which was considered 22% in 1996, was increased in up to 4.6. It was more than the breast cancer and other non-communicable diseases. It was highlighted in the study conducted by Dr. Sultana Habib. You can see the increased incidence of mortality from the acute myocardial infarction in women by black dots. Despite of the gender difference, sex difference, there was increased incidence of acute coronary ischemic heart disease in men. Probably the reason was underdiagnosed coronary artery disease in women due to the microvascular disease, whereas in men there were atherosclerosis take place in the coronaries. We don't have the data from the coronary angiography from the previous decades because it was introduced in the late 80s in Pakistan, and working on that data from the angiography later on, we found that the microvascular disease was more common in women, whereas males were having large coronary artery disease, and they can be easily labeled as a coronary artery disease having. So later on in 2007, there was coronary artery disease epidemics in Pakistan. More electrocardiographic evidence of ischemia in women was found than the men. A population-based cross-sectional study revealed that, in contrast, in men, definite coronary artery disease history with Q-wave in ECG was more prevalent in men than women. 60.1% with 4.0% in men. In contrast, ischemic heart disease and major ECG changes were twice as prevalent in the women as in men. That study was suggestive for these changes. So these findings indicate that 1 in 5 middle-aged adults in urban Pakistan may have underlying coronary artery disease, and women are at the greater risk than the men by virtue of these chest pain and ECG findings. That study concludes that we suggest that ECG changes are not benign in women, which usually the cardiologist and the medical professionals make a mistake in Pakistan and called it a normal variant. And this study indicated that the coronary artery disease may be underdiagnosed in Indo-Pakistani women, and as evident by the discrepancy between the gender differences in doctors diagnose heart attack and ECG changes suggestive of ischemia. As I told, that the interest in coronary angiography and interventional procedures were increased after the 1990, and very few studies on the coronary angiography on female were presented. This was a study which was conducted in the cardiology department of Dow University of Health and Sciences. We can see that there was the increased incidence of 2VD and in age group of 55 to 69 years of age, and 3VD was comparatively less in female, and was given the treatment with these stents. The same study suggests that there is increased incidence in urban areas, and patients were referred from those areas. So 347 patients were included were given the interventional therapy. Total female which were treated in the Department of Cardiology and Cath Lab were 577 out of the 333 male patients which were underwent the procedures. Rural women were comparatively less because of the transportation and other socio-economical problems in this. And the other drugs which were also given then were comparatively less. The BMS stents which were given were due to low price were high in number than the drug-eluting stents and drug-eluting stents and BMS combination in various arteries. In 2018, the World Health Organization shows that there is increased burden of the coronary artery disease in non-communicable diseases in men comparatively to women. Maybe due to the increased tobacco smoking, increased high blood pressure, and obesity was shown more in the women. Now coming back towards Pakistan, there is increased risk profile of 15.9% Pakistani population has one risk factor, whereas multiple risk factors were found in 42% women versus 20% in men. Without tradition, patient have traditional risk factor 3.5 versus 14.3% in men. Acute myocardial infarction with diabetes was found in 61% of the women versus 31% of the men. Hypertension was again more in women than the men. Oral tobacco use and smoking are more common in the men versus women in Pakistan. So the sex differences in coronary cardiovascular disease and the CHD mortality in Pakistan suggests that CHD mortality largely reflects sex difference in Pakistan. This is the picture of my grandmother who was 110 years old. Because of the elderly, she belonged to the rural area, was very active woman and physically involved the various household activities. So over here, female sex is associated with a longer life expectancy than the male. Larger proportion have greatest prevalence of the coronary heart disease. Alarming status among the youngest women, 35 to 45 years of age, with increased coronary heart disease. There is increase in mortality rate from average of 1.3 annually. The prevalence of metabolic syndrome is high in women in Pakistan, 49% versus 34.8%, leading to cardiovascular disease in 30% of the women. Physical inactivity is more common in urban women, leading to obesity, hypertension, diabetes, especially in the menopausal age. Depression is more important cause due to the social insecurities for the complication after the MI. Coming towards the article which was published in the 2018, it suggests that previously high propensity of the cardiovascular disorder in Pakistani women has been increased. Zafar et al. Initially reported that the women are at equally high risk of developing cardiovascular disease in comparison to men. Later on, NHSP survey declared that women are at the greater risk for cardiovascular disease than the men in Pakistan. Additionally, in 2008, more electrocardiographic evidence of ischemic heart disease was documented in women than in men in one study conducted in Pakistan again. In all these studies, increasing age has been hypothesized as the cause of increased prevalence of cardiovascular disease in women. However, in current study, the risk factors are more prominent at early age. This study shows that there is nowadays the risk factors are almost same, but some variation in the systolic blood pressure as well as triglycerides and the HDL ratio, which is minimally higher than the male. Increased mortality in Pakistan, as we all know that due to the lack of the awareness of the symptoms in women, there is delayed contact of the patient to the hospital. So it usually gives rise to the increased mortality and late treatment of the patients over here. And women are less likely to take ACE inhibitors, ARAs, lipid-lowering therapy, and to achieve the antihypertensive therapy to achieve the blood pressure goal less than 140 by 90 millimeters of mercury. They are less likely to take antidiabetics and the statins properly. So they may suffer from the more complication than the men because of the socio-economical problems as well. So what should be the preventive strategies in women and future plans? Our only option is to prevent it. Therefore, we need to develop a national awareness project to address the problem. It should be stepwise, starting from the policy making at the government level, then awareness at the level of healthcare individuals, and then awareness at the public level, and lastly, implementation of the policies. If we are able to target the risk factors earlier, then effective preventive interventions are there to reduce the prevalence of these diseases in women in Pakistan. So I will conclude my presentation by highlighting that sex differences in treatment rates might underpin some of the differences in control rates due to the deferred management across the regions of Pakistan, suggesting the need for the tailored strategies to reduce these inequalities and to improve the uptake of the guideline recommended care for the secondary prevention of coronary artery disease in both men and women, and more in women. After joining the GORED for Women in Pakistan, we conducted in 2019. We conducted many workshops and programs in Pakistan, but now they're restricted after the COVID-19 in Pakistan, and they conducting various webinars for the awareness of the doctors, for the awareness of civil society, and trying for the better health care for the women in this hard time. Thank you so much for giving me opportunity to present back.
Thank you, Dr. Khalda. I really appreciate your insights of cardiovascular disease, and especially with a focus on women. And I know that this reflects your personal journey of many years serving the public sector in Pakistan. So thank you very much for joining us. I know we've had some IT issues. You were supposed to be at AKU, but there's some, as usual, some traffic and sit-in issue going on the roads, and that prevented that. So really appreciate you being able to join us from a different location. So if we don't have much time for Q&A, but what I'm going to do is shoot out 2 questions to all the panelists, and we can go in order here. If Dr. Jamil Tajik can put on his video, and then we can get started with these questions. The first question is, and it's interesting, I've actually seen the sunrise behind Dr. Tajik over the course of this session. So thank you for sharing that with us. The first question is, in your professional cardiovascular practice that has spanned several years, how have you seen gender highlighted? And maybe we can begin with Dr. Tajik. You're on mute, by the way.
Thank you. So Zainab, as you know, my past as the chairman of cardiovascular department at Mayo Clinic, I was instrumental in hiring on the faculty most women cardiologists ever. The percentage of women cardiologists at Mayo at that time, during my tenure, rose to 15%, while at ACC in those days, it was 7%. So we promoted, and now that trend is all over the country. I don't know whether Dr. Lansky is still on or not. Is she there on the question answer?
No, she had to leave.
Yeah. So she indicated there are not many in interventional cardiology, and that's the truth. That is well known, and it has to do with life and other balances that they have to balance as well, women. So I think that's being the same aspect for cardiac surgery. Not many cardiac surgeons are women. So these are the reasons behind. There are several and very obvious ones. But women are everywhere, taking over.
That's a good thing. I think the world would be a better place with more women.
And we are all behind it.
That's right. I have to say, Dr. Tajik, that I often tell both Zainab and Saira that they had the personalities for interventional cardiologists, even though they decided not to become them.
Yes, I think we were more far-sighted as far as that decision was concerned, just given how courage and other things have rolled out. So Dr. Butler, the same question to you.
I mean, I think, I can give a normative answer about sort of the right and the wrong and why this should or should not be. Obviously, I'm a father of 2 daughters, so making the world a better place for women is also personally important. But I actually would rather give an answer from a more practical perspective and not from a normative ethical perspective. And that is that as a society, if you want to progress, I want to be really selfish and tap into this mass of energy and intellect just sitting there, 50% of the population. Like, how can you even expect to reach your fullest potential when you leave 50% of the population behind? So, I mean, we can have a normative talk, but it just practically doesn't make sense to be completely open and promote women, because it will just be good for the society only for that practical reason.
It is so sad to be listening and talking like this in the 21st century, 2021, that we are talking like this, that promoting women should be done. It's sad for me for the humanity aspect, that we have not achieved that by now.
Yeah, so this whole thing about celebrating Kamala Harris becoming the vice president of US, on one hand, I can understand why we should celebrate. On the other hand, I sure hope that in my lifetime, we live in a world that it's actually not a reason to celebrate. I mean, this is it. I mean, so we'll see.
Thank you. Dr. Khalda Sumro, your insights on this.
So I will say that in South Asian countries like Pakistan, where there are social barriers in the setup, and women need a woman cardiologist. In our country, more women will serve more women patients, and that will be the privilege of the country.
Agree, and I think we don't have more than 60 cardiologists, right, in all of Pakistan, and that's 220 million people, and half of that are women. So that your point is very well taken, Dr. Sumro. Appreciate it. So my second question is, I think we only have time for 2 questions. Again, I'm really, really happy and grateful to you all for staying on and taking these. My second question is, what can we do as a cardiovascular community to improve the care of both men and women? How can we put a gendered lens on the work that we do or the clinical care that we provide? So Dr. Tajik, again, first.
I would, before, this is the last question. Is that right? So
Yes.
before you finish, I want to say quickly something. To my brother from another mother, I'm told he's watching, Professor Samad. Salaam alaikum, bye. Sange. I wish he could reply at this time, but at least he has my greetings. Huh? So, okay, the question is, how can we help women? Is that what you want?
Well, no, the question is really, how can we have a more gendered approach to cardiovascular practice in the future? How can we think about, like, you know, this affects not only that we thinking about the right diagnoses when a man or a woman walks in, but also how a man or woman would want to be taken care of. You know, how do we fashion our facilities to recognize preferences of each gender and the nuances of each gender in cardiovascular disease?
So I think Dr. Sumrok very aptly mentioned that societal forces play a major role here, okay? Where we are right now, Dr. Butler, myself, Javed, there's no difference, you know, whether a man walks in or a woman walks in, we're greeting them, meeting them, treating them almost exact the same way. There's not looked upon any difference, whether gender, whether color, whether, you know, religion, whoever walks in, we are treating them exactly the same. Farmer, president, whoever they are. So that's what it is, but depends on where you are practicing. That's the determinant, you know. You go to Middle East, it's a whole different ball game, you know. So it's completely dependent on where you are.
Thank you. Dr. Butler?
I mean, I think, you know, so this will require some process engineering, right? I mean, it won't happen. So if we become too idealistic and want to sort of, you know, legislate everything and want things to change tomorrow, then I think the system has a little bit of a backlash. And on the other hand, if we just keep the status quo, then sort of nothing changed. At least from my perspective, you know, the 2 things that I would say is, you know, shining the light on the issue. So like this forum is one thing, but just keep at it. Keep, you know, shining the light at the disparities, the disparities not only in terms of the patient and their outcomes, but also disparities in terms of the healthcare workforce. And then the second thing is that we have to train more female cardiologists and more female physicians, because there is a cultural bias that a lot of women in our societies would prefer not to be very open with male doctors or even seek care in certain settings. So having a bigger female workforce will be very important. But also my first comment about shining light to the issue is the more women workforce is out there, it automatically will translate into shining more light into it. So I would say probably if I have to do one thing, and I know it's a very sensitive issue because then the question comes up about, you know, meritocracy and quota and this, that, other, but having some sensible interventions put in place to train more women, to lure more women to come into the medical schools, but then choose subspecialties that have traditionally been more heavily favored by men, train more women and just keep at it.
Thank you. Dr. Khalda Sumro?
Yes, Doctor, in my career, since last 38 years in cardiology, I'm treating more women than men because they can express them. Female patient can express in a better way to a lady cardiologist, and we can, being a lady cardiologist, we can understand their symptoms and their psychological behavior and other social problems in a much better way and to treat them accordingly for that, which a male cardiologist in our society cannot do.
Thank you, Dr. Sumro. Dr. Tajik? Tajik, you were going to say something, I think.
No, I was going to ask you, what is the proportion of students, female students in your university?
It's actually 50-50, I think. Yeah. And
Wonderful.
that obviously that took work. I mean, Dr. Butler is talking about, the sensitivity around quotas, but there was a time in the 1960s and 70s, and Dr. Tajik, you may remember that in medical colleges, they actually had quotas for women. There was an active push to actually draw more women into the medical school. And so I think it's that effort that's paid off now, several decades later. But thank you. This has been phenomenal. We've heard from the epitome of every specialty in cardiology right here. Dr. Butler talked about heart failure. He's the man. Dr. Tajik discussed one of his favorite topics, which is mitral valve prolapse. And it's specifically a disease that we see often in women. Also sudden death, that the light's been shining on this more clearly over the last few years. Dr. Lansky described how her career, and that's really an inspiration, especially for women at a time in a field that they generally don't choose to go to for a variety of different reasons, as Dr. Tajik earlier alluded to. And Dr. Sumro, thank you for sharing your personal insights and really describing the landscape of cardiovascular disease in Pakistan across different genders. I will now hand it over to Dr. Usman Fahim to give his closing remarks. Thank you very much.
Thank you, Zainab. I think we're wrapping up a fantastic inaugural session where we've had some wonderful speakers. And, I can only add to what you've already said, and thank all of the people that took time to make this kicking off session so successful, from Dean, Adil, Heather, and CEO, Dr. Shafi, as well as our chief guest, Dr. Zafar Mirza, and our keynote speakers, Dr. Lansky, Dr. Jamil Tajik, Dr. Javed Butler, and Dr. Khalda Sumro. I'd also like to thank Zainab herself and Dr. Saira and Dr. Thai and Dr. Amir Hamid, who organized this. And, there's so many people that go, that play a role in successfully kicking off any conference. And, the people behind the scenes is Sana Makhani and her team, as well as the students, Vikas Shah Nawaz, Ali Ahil, Maha Inam, Abdullah Khalid, and Umar Arif Isfahani, and the IT team at AQ. I think, we're all trying to do what we can. And I think it's clearly gender matters in cardiovascular disease, as we've discussed today. I'm happy to see that at AKU, there is almost half the residents in cardiology are women. And, Dr. Saira is a graduate of our program, and, she's had fantastic achievements, and we're looking forward to the future graduates achieving great things. I'd like to thank our cardiology residents as well as the rest of the faculty. But I think the first session has been tremendous and a learning opportunity, and covered a diverse set of topics. That goes to show how wonderful our field of cardiology is, where you can, in 3 hours, talk about your career and talk about mitral valve prolapse and advanced heart failure, and as well as your clinical experience in an LMIC of cardiovascular care over 30 years. So really thank you to all the participants for taking time out and joining us. And we're looking forward to a continued participation over the next 4 days. Thank you very much, everyone.
Thank you.
Thank you.
Thank you.
Khuda Hafiz.
Take care. Khuda Hafiz.